Good afternoon. This is Elizabeth Cote. I'm the Chief Health Officer at NICHQ, and I'd like to welcome everybody to this webinar. We are going to wait 1 or 2 more minutes as people continue to log on and join us. We have over 400 people registered for this webinar today, and we're going to make sure everyone can get through a few technical hoops to be in the room, and we'll start shortly. Okay, well, we are ready to roll. Good afternoon. Again, I'm Elizabeth Cote, the Chief Health Officer here at the National Institute for Children's Health Quality. And we today are hosting a seminar. We are really lucky to be the collaborators of a group of experts in Medicaid policy and how to make Medicaid policy work for children. Our first presenter is going to be Debbie Chang, and we have a lot to cover today with some really fantastic speakers in addition to Ms. Chang. The first 45 minutes of the webinar will be led by Ms. Debbie Chang, who's the Senior Vice President of Policy and Prevention and a Corporate Officer at Nemours Children's Health System. In this role, Ms. Chang works to leverage Nemours' expertise and experience to spread and scale what works through national and policy practice changes to improve the health and well-being of children nationwide. She has more than 30 years of federal and state government and private sector experience in the health field. For example, she's held key government positions, including Deputy Secretary of Healthcare Financing at the Maryland Department of Health, with oversight for the Medicaid program. And she was the National Director for the State Children's Health Insurance Program when it was first implemented in 1997. We have many other leaders of this caliber waiting for your questions. The question and answer period will be after the 45-minute presentation. At that point, we will introduce the panel of experts before opening up to your questions and answers. You're welcome to add your questions to the chat box at any time during the presentation. We'll be keeping track of them and highlighting them, then feeding them to our panelists when it becomes time for Q&A. The goal of this is to connect some of the nation's experts in how to make Medicaid work with children with the folks on the ground who are trying to make life work for children. So we hope by the end of this, you feel a little bit more like you can be a policy expert or at least an agent of change using Medicaid policy. I'm now going to turn it over to Ms. Chang for her presentation. After one more brief reminder that there'll be plenty of time for Q&A at the end of Ms. Chang's presentation, but we'd like you to use the time during the presentation to start submitting your questions so that we can answer them efficiently and distribute them among our board of panelists. Welcome to this community and welcome to Ms. Chang. I'll now turn it over to you, Debbie, for your presentation.
Good afternoon, everyone. Thank you for that kind introduction. It's really an honor to be a part of this, and I really want to thank NICHQ for gathering not just myself, but this great panel that you'll hear from later on after my presentation. So what I'm going to try to do in about 45 minutes is a couple of things. At first, I'm going to spend a little bit of time, the first 2 bullets, just 10 minutes on, why would you want to work with Medicaid or have CHIP at the table? How do the Medicaid and CHIP programs work, just very generally, so you have enough background, and then spend the rest of the 30 minutes on the third bullet, which is strategies for early childhood experts to engage with Medicaid and CHIP agencies and staff, and of course, examples of collaboration in hopes that this can help you with your work on the ground. So in terms of the next slide, just a little bit about Nemours. We're a children's health system that operates in northern central Florida and in Delaware Valley, dedicated to children's health and healthcare. And a part of Nemours is a big pediatric health system. The part I oversee is our national office, where our goal is to improve health and well-being of children nationally, while leveraging Nemours' clinical and population health expertise. And that includes advocacy and systems change, policy change, and prevention programs. And one of the things I wanted to share with you to give you a sense of where Medicaid people are. I was a Medicaid director for 5 years in Maryland, and I wanted to show you this next slide because as a health system going upstream and trying to address prevention and for children, we've had to make a shift from the traditional medical model to a more expanded approach that includes promoting health and prevention, much of the things that you all do. And so, we've had to move from a biomedical view to a more multifaceted view. And I wanted to share this shift for you because it's the same kind of shift that's happening with Medicaid directors. They're primarily on the left-hand side, focusing on health care and clinical issues. And in the last couple of years in particular, there's been a expanded view of health to include the social determinants of health and population health. And so I'm trying to give you a sense of kind of where the heads of Medicaid people and CHIP people are. And so, it's really moving from a biomedical view to a more expanded view. So from a biomedical view of health to multifaceted, from a focus on acute, more episodic illness to a focus on disease prevention and management, from a focus on individuals to much more of a focus on communities and populations. And that's one of the biggest shifts, because Medicaid is a program, it's an entitlement program for individuals to get primarily health care. And so it's a real shift for Medicaid and CHIP folks to then start thinking about, well, what am I doing for the whole community and for the population as a whole? And also a movement from cure to a expanded approach that really focuses on prevention, especially for children, from a focus on disease to a focus on health. And so Medicaid directors and CHIP directors are in various places in this spectrum, but a lot of people are on this left-hand side. And so I thought it'd be helpful to kind of give you a sense of where folks are. Why would you want to invite Medicaid CHIP to the table? That's the next slide. The major reason is that we really serve the same low-income population. The early care and education sector, the early childhood sector, the Medicaid sector are both serving young children. And as this slide says, 45% of children under age 5 are in Medicaid. As many of you know, almost half of all births are covered by Medicaid. Children constitute half of Medicaid's enrollees, although the proportion of costs are much lower because children's health costs are smaller than adults. Medicaid does cover services that link beneficiaries to social services, such as case management types of services. And, the core mission is obviously to provide, healthcare coverage and health clinical services, but partnering really ensures that scarce health and early childhood resources are better coordinated. And so in the next couple of slides, I'm going to just summarize very quickly kind of just some basics on Medicaid and CHIP to ground you for the meat of the presentation, which is really on, strategies for working with Medicaid and CHIP agencies and examples of that. So in terms of Medicaid, I mentioned this earlier, it's an entitlement program for individuals. And that means that the money follows the people. It's not like a block grant to like the MCH block grant that is a block grant to states. It's really an entitlement. That individual entitlement really makes Medicaid and CHIP, different. Now, under CHIP, you can states can choose to set up a private system or use Medicaid. When they set up a private system, then it's not an individual entitlement. But it's really important to know that Medicaid is really a federal-state partnership. While it's operated by the Federal Department of Health and Human Services, it's really a partnership. And state Medicaid programs receive funding from the federal government to match state funds, and the state programs and the match levels vary. And I'll go more into that in a moment. It's very important to note that, as many of you know already, that one thing that is so great about Medicaid is the program for children, which is called the Early Periodic Screening, Diagnostic, and Treatment Program, EPSDT. And that covers preventive care and any medically necessary service. This is important because if something is deemed to be medically necessary, it's covered by Medicaid, even though it's not in the base state plan. So that's a really great program, and it's very comprehensive. And, I would say that, all providers and practitioners in the early childhood space really benefit from it, from childcare providers and healthcare providers and social service providers and the families, because it is one of the most comprehensive benefit package. And then in the next 3 slides, I'm going to go through, really speak to state flexibility under Medicaid. And it's important for you all to know that because it's often said in the Medicaid world, when you've seen one Medicaid program, you've seen one Medicaid program. There's tremendous state variability. And so I wanted to, these next 3 slides gives you a sense of that. So states have a lot of flexibility in setting and shaping Medicaid. There is a basic, package of benefits, but there are optional packages. There are certain minimum requirements in terms of coverage of certain populations, and then options to cover additional folks. Increasingly, states are relying on managed care organizations. 68% of children are enrolled in managed care organizations. That's important for you to know, because when you think about engaging and working with the state Medicaid or CHIP program, you need to also think about, if it's a managed care state, really engaging and working with those managed care plans. And I'll talk more about that later in the presentation. Under a managed care plan, the the states delegate that authority to the managed care organizations, and they cover the costs of the healthcare services, in this case for children, in exchange for a fixed amount per child. And so if the healthcare costs are less than the fixed amount, the MCO keeps the difference. If it's more, then they're paying more. And this really creates an incentive and flexibility to have managed care organizations cover services related to prevention, and also services that are not necessarily mandated by Medicaid or CHIP, especially if it helps keep the children healthy. There's also a lot of flexibility to cover, as I said, the non-medical benefits or social support benefits, and also use non-medical professionals to provide those services, but states are just recognizing this flexibility. So the factors impacting the variability of programs, one of them is obviously state budgets. The Medicaid accounts for 20% of the state's general fund. It's second to education in states. And the cost of benefits and the state budget impact the decisions on benefits that they offer, as well as, populations and what the reimbursement rates are to clinical providers. Once a population or services is added, it's not easy to eliminate that or scale back. And so states are very cautious about when they are adding a population or service, because they know, they're doing that. On since it's hard to eliminate, they're doing it on a permanent basis. And so they're really thinking very carefully about whether to add a population or add a service. It's also really important to note that, when we think about kids and we think about prevention in particular, the cost savings from that is not realized until a later budget cycle or during the next, governor's term. And so that also impacts a decision on, what states will cover. In terms of state priority setting, that's going to vary a lot depending on how states identify their priority needs, and states approach that differently. Obviously, if there's a new governor, if there's a new Medicaid director, they will set the priorities in terms of what that state will focus on. States often do prioritize children, even though children are a small portion of the total Medicaid costs, as I mentioned earlier. Often states will prioritize the drivers of high healthcare costs. Those are usually adults, particularly disabled and elderly adults. Actually, most of Medicaid costs are spent on long-term care and on complex diseases. So that can, because those areas drive the cost, the priorities can be set by those rather than by focusing on kids. Now, obviously, state advocacy groups and folks in the early childhood space, we can also, elevate issues for state action. There's also clearly some of the variety by states also depends on, who is in place at the federal level. This current administration has made it a priority to focus on state flexibility, on things like work requirements, and on the movement to value-based care as well. So those also impact a state's decisions related to their Medicaid program. And finally, in terms of, the variability depends on supply and demand. States need to be aware of things that increase demand, like poverty levels and unemployment rates, as they think about their decisions. And certainly those, Medicaid and CHIP costs can surge if demand increases. A state can also resist expanding services if there's not enough qualified providers available. The best example for that is mental health. There's a huge need in the area of mental health, as all of you know, emotional mental health, and yet the supply of providers is quite limited. And so states might, you might not want to expand the services if you know that you don't have qualified providers available. So that's just a quick summary on some of the key factors you need to think about. And now I'll move to the next section. The next section is really focused on the meat of what we wanted to talk to you about today, and that is, what are the strategies for you to partner, with Medicaid and SCHIP? So this slide sums up the 5 key strategies, and think of these as a first step to think about as you're thinking about partnering with Medicaid and CHIP. And I know during the question and answering period that the panelists and myself were happy to answer questions and go deeper on any of these. But these are 5 steps that you could take as you're thinking about this. And I'll summarize them and then go through each. And then also, talk a little bit more at length about some of the current realities of Medicaid that can make it difficult and feel daunting to work with Medicaid and CHIP agencies. So the first is identifying a high-level champion within the Medicaid and CHIP program who really believes in improving child outcomes. The second is understanding the current state Medicaid and CHIP priorities and initiatives, and that's why I was, talking earlier in those previous 3 slides about how do states make some of their decision, what actually motivates them to make certain decisions. This is important because the best way to make the case for a partnership is by emphasizing shared goals and shared populations. Often, having been a Medicaid director for 5 years, often you feel like you're the piggy bank because people are always coming to you for this great thing that they want you to pay for, or this way to save money, or and so you always feel like people are coming to you for the money issues. But the case, when people came to me and laid out a case that they wanted to partner with me because we had these shared goals to address child health in the early years, for example, and we both work on these populations, that to me was a more compelling argument. The fourth thing is that it's, really challenging to start a partnership if you don't understand the basic structure of the Medicaid CHIP program. I went through quickly some basics, but that there are other resources through different websites that I can refer to in a moment when I get to that slide. But it does help to have some basic knowledge of the program so that you can begin that relationship building and the trust building that's so important for partnerships. And the fifth thing is to really jointly work together once you've established a partnership to identify and pilot a small initiative that's connected to your shared goals. And starting small is a great way to win trust and start the relationship. And all of this is in a paper that we just released called Early Childhood and Medicaid Opportunities for Partnering. And you can see on this slide here that we've put down, exactly how to access the paper. And I wanted to say too that the paper was designed with an audience like you and mine. It was really designed for kind of early childhood audience to approach Medicaid and CHIP agencies. We've done a lot of work in this space, looking at the other end as well. If you're a Medicaid director, what are the current authorities that you have to, focus on prevention and the social determinants of health? But this one is particularly written for you all in mind. And it was supported by the Alliance for Early Success. So now let me go through each one. So this first one I talked about was, identifying a high level champion. Certainly engaging the Medicaid director really helps. And so in the work we've been doing in Washington State, we actually worked directly with Marianne Lindeblad, one of the most progressive and really wonderful Medicaid directors. She worked for the state of Washington. But also it can be the key maternal and child health leader. Or it can be the chief medical officer. Most Medicaid offices have a Medicaid medical officer. So it doesn't have to be, the Medicaid director, him or herself. Also, each state has a Head Start collaboration office, and depending on the agency employing that director can be a champion and help to negotiate partnerships with early childhood and Medicaid and CHIP. As I said earlier, instead of approaching the stakeholder, for funding, it's really important to establish the relationship based on shared concerns. And, often you might want to start by identifying some senior level staff who really sees the potential of Medicaid and CHIP as a partner with the community, and likewise to look for Medicaid staff who has experience in the early care and education sector, because these individuals tend to have more experience understanding how programs interconnect to serve a given family. So that's quickly on strategy number one, and I can go into a lot more detail during the question and answer. But I think, when you've identified the champion, the other thing you really want to start to do is build that relationship and really understand what they need. What do they need to promote the collaboration within the agency? So the next slide, strategy 2, is understanding current priorities and initiatives. And as I said earlier, that's really important because the best way to form a partnership is to develop joint and shared goals, and to understand what the priorities are and the initiatives of the Medicaid and CHIP directors and agencies, and understand how your initiative fits into that, or to find an initiative where, there's a win-win, where you have shared goals so that what you're doing helps what you want, but also really helps the Medicaid and CHIP agencies. It's helpful to explore strategies that can be built into existing initiatives. So if, for example, there's an existing waiver, like in North Carolina, they just approved a waiver, instead of pursuing a new waiver, because waivers are very hard to get. you want to build on what's already there. So that's why you need to understand the program, as I said earlier. You also want to understand the Medicaid and CHIP data and understand the health landscape to determine, how do you shift the focus to young children. So, for example, in the area of obesity, 30% of children are now either overweight or obese. And so if that's an area you wanted to work on, coming with data to show your Medicaid and CHIP agency staff would be an important, first step. I'll also say that a great example of this is in the state of New York, where the state Medicaid and CHIP agency has developed a priority to focus on the first 1,000 days. I know many of you know about this. And they developed, as a part of that, performance metrics for the MCOs based on coverage and care for young children. And so, you're coming in and understanding that and understanding how what you want to do fits into that would really help to, help that relationship building and the partnership. It's also really important to understand what kind of childhood quality metrics and data are currently being collected, to understand how what you're trying to focus on, how does that feed in to what's already a priority for, the CHIP and Medicaid programs. So, understanding these metrics, there's a lot of metrics, and understanding which ones are currently a high priority for that agency would be key, so that you can help support that state in what they're trying to do. And it should be noted, too, that Medicaid and CHIP agencies voluntarily collect and report metrics that are determined by the secretary to drive quality improvements. And so those are optional now, but in 2024, they'll be mandatory. And so if you can find areas where what you're doing kind of feeds in and helps supports those goals, that can go a long ways in terms of establishing, a partnership. The third strategy I was going to talk about to that point is actually developing shared goals and working with the same population. So helping the Medicaid and CHIP leaders understand the performance metrics and federal requirements across sectors, so they can see that it's mutually beneficial to focus on these things. So, for example, home visiting programs ensure that, one of the things they do is to ensure children receive immunizations and well child care visits. Those are very often a key goal of Medicaid and CHIP. In addition, if you're a state that has managed care programs will have case management services especially for children with more complex needs. At the same time, we know that in the early childhood sector, many of those programs are also dealing with the same kids. And so if you can, coordinate with the managed care organizations on what they're doing for kids with complex medical needs, again, that is a way that you can have some shared goals and work on similar populations. I mean, clearly one of the areas that are ripe for shared goals and populations really is whatever the priority is of the incoming, governor or the current governor, and the legislative leadership as well. And certainly in states that prioritize collaboration, those can also help to enable the partnerships. So that's strategy number 3. And then strategy number 4, I'm just summarizing these, is that, as I mentioned earlier, really trying to understand your state's Medicaid and CHIP programs. And there's some great resources, many who are on the panel that you'll hear from, but also 2 websites have information on state programs. One is the Medicaid website at the federal level, so that's www.medicaid.gov, and you can get all sorts of information. There are searchable databases on state plan amendments and on waivers that can tell you about the basics of the program in your respective states. Another website that's great is the Kaiser Family Foundation, and that is www.kff.org. Again, they have a wealth of information, and as I said earlier, the panelists also have a wealth of information. But coming and reaching out to your Medicaid agencies after you've learned a little bit about the program is important. So you want to get a sense of what the relevant authorities are that the state already has in place. For example, does the state have a waiver? Does the state have a home health program or a healthy homes program? And you can find that out from some of the sources that I mentioned earlier. You might also want to know whether or not services are provided in community settings using non-traditional providers. So, like in the state of Minnesota, they have used community health workers. Some tend to use a school-based nurse model as well. So you want to know basically what kind of authorities the state has in place. In addition, it's really important, as I mentioned earlier, to know whether your state is a managed care state or a fee-for-service state. And as I mentioned earlier, 68% of children are in some form of managed care. And that makes a difference because if you're in a state that has managed care, then you need to not only work with the state, but you often need to work with the managed care plans. So I think I've covered some of this. The other thing to know about managed care is the managed care plans often have metrics and goals that they're trying to reach, like increasing well child visits or decreasing emergency department admissions based on asthma, for example. And so, knowing what their goals are and what their objectives are important because, again, you can see how what you're doing fits in and can feed into what they are already trying to do. Also, if you're in a managed care state, in terms of working with the state, because one way to, states vary in terms of their contracting requirements for managed care organizations. Some states have been successful in having requirements related to, certain things for children, for example. And so you want to know what that process and timing is to add new requirements. Also, learning what incentives exist for managed care organizations to add services is really important because managed care organizations do have the flexibility to add non-medical but health-related services and other kind of value-added services. Generally, the way to do that is to build the case with the managed care organization that what's ever being added is helping to keep that family or child healthy, to prevent the costly services like ED visits and hospital readmissions, for example. I already talked about the annual performance targets, that it's really important to understand whether the state CHIP or Medicaid program and or the managed care programs have specific performance targets, because again, you can try to assess whether the work you're doing in the early childhood sector can help support the state in doing that. And finally, I know Debbie's going to talk about this later, the other Debbie. The states are required to have an interagency agreement between the MCH block grant and Medicaid and CHIP programs. The purpose of that is to have coordination and collaboration. So finding out about that can be really important in terms of, again, seeing how what you're doing fits into what they are doing. And finally, it helps to start small and to do a small pilot on an initiative that's connected to a mutually shared goal. And the first thing to do there is to really define what the problem is, and to and then to understand how the CHIP and Medicaid and EC sectors interact around that problem, and then to set a bunch of goals and objectives relating to the cross-sector efforts. and to really clarify the roles of different partners, by selecting who's the lead entity for planning and figuring out, what services Medicaid can pay for, what services other partners need to pay for. And I'm going to give you some examples of this because we're in the middle of working with 3 states on 3 different pilots. And I was just got off a phone call with the District of Columbia and the pilot that we're working with them on. So with that, let me also spend some time just before I go into these Nemours projects, giving you a sense of the realities of a Medicaid and CHIP staff, so that you know that going in and have that perspective. So I gave you that first slide that kind of showed that that most state Medicaid and CHIP directors are on this continuum in terms of being a totally clinical program to starting to look at the other social determinants and developing cross-sectoral initiatives. And so that really varies quite a bit among state Medicaid and CHIP programs. But I think in terms of some of the challenges to partnering with Medicaid and CHIP is the first thing to kind of know is that there's often limited administrative capacity at state agencies. You all know that. And from a Medicaid director's perspective, you're always fighting fires, and you're always short-staffed. And also the average tenure of a Medicaid director is, I think it's now 18 months or 19 months. So it's less than 2 years. And so priorities can change quickly. And so that's why, finding a lead kind of career person is often helpful, because that person's gonna be around for a while. So just a little bit about the administrative capacity. It's often really helpful. Like when you're doing the pilots that we're doing in the 3 states we're working in right now, we're kind of extended staff for the Medicaid folks. And so we do the background research. We come up with the pilot. We, of course, pass everything through the team that we put together. But we end up doing a lot of the staff work. So that's another thing you might want to think about in terms of how best to help them, because they're so busy, and you need their engagement, but you want to make it as simple as possible for them. You really want to kind of serve it on a silver platter for them. The other thing that, and you all know this, is that the return on investment for focusing on kids, both a managed care plan and from the state Medicaid and agencies' perspective, that's not the hugest driver of costs. And when being kind of realistic in terms of budget windows, when you might invest a lot in kids, but you might not reap the benefits, or you might not think you're going to reap the benefits in the political cycle, or or even in the MCO contract. There's a lot of churning in managed care organizations. By churning, I mean that that the enrollees will change plans from year to year. So you might make an investment as a plan only to find that kid has now moved to a different plan. And so you might not feel like it's worth your investment, so to speak, to engage in an initiative around that, for example. So just knowing the return on investment is really important, and trying to build your case around, what's the important case for investment for that managed care organization or for that state agency. In addition, Medicaid, it is a clinical program, and so you've got a lot of providers. And you're dealing with, a kind of a provider-driven program where providers are very focused on reimbursement rates, and there are different provider requirements. And so, getting the attention of Medicaid directors and CHIP directors can be challenging, because they're, focused on a lot of provider-related issues. And I guess finally, I'd say that technology, depending on the state Medicaid and CHIP programs, technology can often inhibit innovation. Let me just say it that way. And just something to think about. Now, there's some states that have very advanced databases and technology. So it just really varies. So with that, let me get to the final part of my presentation. I'm just looking at my watch here to make sure. Okay, I've got 10 more minutes. I'm going to go through some examples and just first tell you about, so we've been working, because of my background on Medicaid and my background on prevention, Robert Wood Johnson Foundation gave me a grant to look at the existing authority under Medicaid to support prevention. And actually, thankfully, there's a lot of existing authority to support prevention. And part of it is making that mental shift that we need to from a health system focused on sickness to a health system focused on health and well-being. And so this slide just speaks to a set of a toolkit that we developed. Now, the audience was states, and so it's organized to help in the way state Medicaid agencies think about things. And we have some case studies here on this one. The next slide is, we came up with this roadmap for prevention, and so we then got another grant from Academy Health to look at testing payment strategies. And so again, if you're interested in this, in particular, we worked in 3 states, Maryland, Oregon, in Washington. The one I'll raise up is under the managed care regulation of 2016. Managed care plans, as I mentioned earlier, can add value added services that are non-medical, and they can also provide community care coordination, which is like case management. Maybe another word for case management, but that it has to link the clinical service to the other social services, and Medicaid managed care plans can pay for that. So with that, then we went, and our next phase of this project that we're in right now is really developing 3 pilot programs working in early care education, so child care and Medicaid. And from this work, we're going to develop a how-to brief. Everything will be on this website, Moving Healthcare Upstream, and there's a Medicaid link that has all of the Medicaid resources. So that's a little on that project. And then I'm going to go into 3 examples, what we're doing in DC, in Washington State, and in Maryland. And if I have time, I'll go through some other examples as well. I'm just looking at my clock to look at the time to see how much time. Okay, I've got about 7 or 8 more minutes. So in Washington, in the District of Columbia, we're working to increase the rates of early childhood developmental screening, including mental health screening, and more importantly, to improve the coordination of the multiple systems serving children on Medicaid. And that really is the main goal in the project in DC. We're getting very granular here. We're working with 1 managed care organization and 1 child care center, and we're looking at the flow of information in each of those respective settings. And so we're trying to increase shared information, because what we are finding is the ASQ, the developmental screening, that's a certain type of developmental screening. It's happening at the pediatrics office. It's also happening for the same child in the child care center. And so we're trying to figure out how can they share information. Because they're both serving the same kid and family, and then often the families having duplicate numbers of screenings. And so we're looking at the different workflows in terms of how to share that information. And we've come up with something we're about to pilot. And basically it's that, when the kid's getting their screening with their pediatrician, they're going to staple that to this form that's required in the District of Columbia for childcare, for a particular set of child care centers. And then that family has to bring that to the child care center. So then the child care center has in their hands the screening. And so then they know that they don't have to do the screening. So that's an example. And then we're trying to look at it the other way too. If I'm at the child care center, how can I get information about that child's, from that child's pediatrician, right? About the screenings. And so we're looking at it in a bi-directional way and getting quite granular about it. And we're lucky to be working with a great group of people from the District of Columbia, the Medicaid program, OSSI, the Office of the Superintendent's Office, and Children's National, and getting very detailed on how we can work together. In Maryland, we're working with Head Start and worked to embed a dietitian in a Head Start center to actually bill for services. And so this involved working with one managed care plan to get one dietitian enrolled as a provider, meeting all the the licensure and credentialing requirements of that managed care plan, so that dietitian could then serve children on site at Head Start. And you'll see here that the pilot's on hold because we went through the whole process. We got the dietitian enrolled. And so, this is kind of breaking a barrier in Medicaid where, where a provider, a non-traditional provider, in this case, dietitian, is actually providing a service in a different setting, right? Because most of the services under Medicaid are provided in a clinical setting. So this is providing it in a different setting, and we were trying to test that. And everything was going well. And then, I don't know if my friends from Maryland are on, when we did the screening of the data through Head Start, we found that that in terms of the number of children with a BMI higher than, that was in the obese category, there were only 2 children. And so that raised a question from the dietitian's perspective of the volume of services. Did it make sense for her to set up shop and Head Start when she only has 2 patients? So it's a good lessons learned throughout this project, even though it's currently on hold. I'm not going to go through Washington State because it's very similar to Washington, D.C., except that in this case, what we're trying to do is increase well-child visits. My last slide in terms of other partnerships is that, these 3 examples where in Minnesota, they identified a standard screening tool and that the ECE childcare providers use, that the physicians accept, because that can be an issue as well. And then we've also, there's a quality improvement project that improves the referral links between clinic and early care and education. In Atlanta, there's a great program called Healthy Beginnings in the EduCare Center there that's using nurse navigators from Atlanta Children's Hospital to help families navigate services. Now that one is not getting reimbursed through Medicaid, but it actually could be reimbursed under Medicaid, and we were in some early discussions with folks about that very issue. And finally, in Vermont, what they did in Vermont I thought was really unique. The physicians actually helped to train the child care providers to conduct the screenings that are actually paid for by Medicaid. So that's a case where a non-traditional provider is actually, conducting a screen that's paid for by Medicaid. And that training by the physicians really helped in resulting in the physicians accepting the screening results and incorporating them into the medical record. So with that, I will stop. I think I'm at my 45 minutes.
Thank you so much, Debbie. This is Elizabeth again for a very, very rich presentation. We're now going to turn the conversation over to our wonderful panel of experts who will join Debbie in taking your questions. Some have come in before we even opened up the chat room, and now's a great time to keep forwarding those to us. So along with Debbie Chang, our panel includes Debbie Cheatham, the Senior Technical Assistance Specialist for 0 to 3, Christy Blakely, our Family Engagement Expert on the Early Childhood Comprehensive Systems Collaborative Improvement and Innovation Network, and Donna Cohen-Ross, the Vice President for the Center for the Study of Social Policy. Again, I want to encourage you to send in your questions, and I want to remind you that everyone is going to be able to access a link to this recorded presentation and to the slide deck after we conclude. So thank you to our panel for taking these questions. I'm now going to turn it over to each of them to provide a little bit more information about their expertise as they go around the squares and introduce themselves. You'll notice that we include hints on each panelist's slides about the questions you might want to ask them. And remember, when adding your questions to the chat box, please also reference your state and agency, and if there's a particular person you'd like to address your question to. Debbie, back to you to start our circle of self-introductions around the square.
So I think I mentioned earlier, my background. I think you can ask me about a number of different things. One is the Medicaid Authorities for Prevention and related payment strategies, also about policy and systems change, and the social determinants of health. Did you want me to go into more detail, Elizabeth?
I think you're a well-known friend to us now, and I think it's wonderful to know the work you've done, so we know what to ask you. And we'll pass it to your colleagues, Debbie, Christy, and then Donna, to give a little bit more of an elaborate introduction of themselves, since they haven't been able to familiarize the folks on the call with their work as much. So Debbie, to you. And please remember to unmute your microphones. Tell us a little bit about the work you do and what we can ask you about. And if Debbie Cheatham is not ready, let's go to Christy Blakely. Christy is our family engagement expert. Tell us a little bit about yourself and what we can ask you about.
Hello. So I have been working with NICHQ and other entities in this world of health and funding policy related to Medicaid for 30 plus years. I have an adult daughter with significant disabilities that lives in the community with a partner, and I currently sit on a number of boards for Medicaid in Colorado, and I contract with Medicaid in Colorado when they have their most difficult kiddos, the ones that are hitting more systems or have more complex needs, and funding is a problem. So you can ask me anything from Medicaid and policy to funding to family engagement and how to engage families and bring along leadership. Systems change. I do know a great deal about home and community-based waivers and early periodic screening, diagnosis, and treatment, which is the EPSDT side of the Medicaid kiddos, Medicaid for kids, and accessing services. So I work on the early childhood collaborative, but I'm also the family voice of making sure that we can engage the families, because oftentimes they can ask for things that others can't. That's it.
Thank you, Christy. And now Donna Cohen-Ross, we're lucky to be joined by Donna, the Vice President of the Study of Social Policy. Donna, can you tell us a little bit more about yourself and what kind of questions we can lean on you for answers?
Great. Thank you so much, Elizabeth, and thanks, Debbie, for a great set of slides and conversation about Medicaid and CHIP. I currently, as you can see, I'm a vice president at the Center for the Study of Social Policy. I have a long history with Medicaid and CHIP in terms of policy design and implementation, both as at the Center on Budget and Policy Priorities for quite a long time, and also as a senior policy advisor in the previous administration at HHS. I was there for 6 years, and have a long history in working on the intersection of health and early learning, which of course is the reason we're gathered today. You can ask me about policy design and implementation of some of the strategies that you heard about today, but also some additional ones. I hope when we get to it that you'll ask me about some of the recent success that we've had using CHIP, health services initiatives using unspent CHIP administrative dollars to support strategies for fostering early literacy and social and emotional development among children. I hope that you will find time to ask about Medicaid payment policies to support maternal depression screening and dyadic treatment. Though, that federal guidance is one that I played a strong role in when I was at CMS, and also outreach and enrollment strategies to boost health coverage for children and parents. We have still many children and an even greater number of parents who are eligible for health coverage but not enrolled. And unless eligible people are enrolled in health coverage, all of the wonderful benefits and opportunities that we've been hearing about will not apply to them. They need to be enrolled. And so there's a strong role that we can play in making sure that people have the health coverage that they're eligible for.
Thank you, Donna. You did a great job telling us exactly the areas we can ask you specific questions about. And we couldn't emphasize enough that, especially even for this audience, from families to family advocates, that the number one activity is make sure people are enrolled. I'd like to turn now to Debbie Cheatham. She is a nurse and she has a master's, and she's a senior technical assistant specialist at 0 to 3. Debbie, can you tell us a little bit more about yourself and what kind of questions we can ask you? Well, I'm going to tell you a little bit more about Debbie in the hopes that we know she's on, but is having a little bit of microphone problem. She's a doctoral nurse practitioner prepared to serve maternal and child health populations, especially children with special health care needs. She formerly served as the resource specialist for Project Launch, and prior to joining 0 to 3, she served as the clinical director for the Office of Child Health and the former director of the Children and Youth with Special Needs Unit and Title V funded Children and Special Health Care Needs in Georgia. You can ask her about public health, state government, and Title V, as well as ideas specifically on how ECCS can partner with Medicaid. So we know Debbie is on the call. She may not be able to speak, but we'll tap into her as we are able. So thank you all. And our first question is actually surprise, directed at a panelist, Christy, because we want to set the tone to empower families and family advocates to participate in the innovative strategies presented by the panelists. So Christy, as a parent representative, what questions came to mind for you or stood out, just one or two, from our panel regarding the information that was presented by Debbie Chang?
Thanks for the question. I loved what Debbie said and gave some examples of exactly what has been done prior. It always helps to give examples. But I also know that families, because they're the ones interacting with the system, often are the ones that have ideas like, boy, I'd really like X to change. And I really want to ask the folks, the panelists, how they have found families to engage with them, and if they've had successes, and to share an example, because I think working in collaboration with families really makes hits a home run, and it's one of the things that I think we can do when we're interacting with families every single day in the community. So hopefully that was a clear enough question about how have they worked with families in the past? Do they have any great examples?
Yeah, I think so. Panel, how have you included family voices and empowered them in the past in this work?
I could build on the example in the District of Columbia. What we're going to do is we're going to, at the Child Care Center, we're going to, not just child care, well, the Child Care Center, we're going to work with their family engagement specialists, and we're actually going to bring together families to really ask them, what are the problems that they see. We think that, the sharing and coordination of information between clinical and childcare would be really helpful, but we really want to hear from them about, what do they think of this pilot and what are their goals. So that's what we're at least planning to do. We were just talking about it, so I thought I'd just kick off the discussion.
Great, thank you. Anybody else?
Well, we have a lot of questions actually that have come in too, so I am happy to voice other people's questions. One here is, can the panelists comment on how CHIP and Medicaid can support the Healthy Steps model? And this is a two-pronged question about how Head Start can be an entree to working with Medicaid and CHIP. So we have two other partners at the table and how to work with them as families and family advocates.
I'm sorry, was that directed at me? This is Christy.
No, it's actually directed at the whole panel. So if anybody could talk about collaboration relationships between Head Start and CHIP and Medicaid, and also how CHIP and Medicaid could support Healthy Steps. So we have questions about both Head Start and Healthy Steps and how they intersect with this work with CHIP and Medicaid.
So
go ahead.
This is Donna. I think there are lots of great examples, and particularly on the Head Start front, it goes back to, and Healthy Steps as well, it goes back to what Debbie had said earlier about focusing on not just populations that the two programs have in common, but also the goals that they have in common. So for example, as I think probably folks on the call know, both EPSDT through Medicaid and also Head Start have goals around child development screening, identifying concerns that might be observable or identified through screens, and then addressing those issues. And so working together to ensure that that the funds that are deployed for screening and identification and treatment are used most wisely is something that Head Start and Medicaid can do together. So for example, one of the tenets of Head Start is to ensure that children have a medical home, that they're enrolled in health coverage, and it's only when the pediatrician, when there's not an opportunity for the child to have the screening and other services through the pediatrician in a timely manner, that Head Start uses its own funds to conduct those screenings. And this is why we have a situation oftentimes that Debbie described, where it isn't that children aren't being screened, it's that they're being screened in lots of different settings and there isn't communication between those settings. So Medicaid and Head Start can work together locally in particular, but also at the state level to make sure that those opportunities are maximized in terms of ease for the family, but also making sure that the resources are deployed in a way that makes most sense. Recently, I heard about a state in which, after referrals were made, a data sharing system can check to see whether there is a claim made for services in the Medicaid program, as a way to verify and understand whether those referrals are being addressed and acted upon. So it's these kinds of data sharing opportunities that also give us a lot more opportunity to make sure that children and families are being served expediently and appropriately. I'll stop there, but there's lots more to say about Healthy Steps and some of the other programs as well, nurse-family partnership, other kinds of home visiting programs where there's a lot of potential intersection between Medicaid and the services offered in those settings.
Thank you, Donna. We did have a specific question about Healthy Steps. And I think in general, encouraging folks participating on the call to reach out to where their strongest relationships are, whether it's with Healthy Start or Healthy Steps staff, and work with those relationships to collaborate, identify shared concerns, and then form those relationships with their Medicaid directors around shared priorities. If you want to say a few more words about Healthy Steps, that will address one of the questions that came in, Donna, and then I have another one on deck for you.
Sure. I think when we're looking at programs like Healthy Steps, like some of the home visiting programs, it's important to, in general, to note that Medicaid doesn't normally support a particular program, but if you look at the services that are offered, let's say in a home visit or in a well visit as part of the Healthy Steps program, chances are those particular services are covered under Medicaid. And so there's a way to look at, I like to think of it as, putting the puzzle pieces together the Medicaid way and being able to support all or at least most of what happens in those settings using Medicaid coverage. Now, I said that most often Medicaid doesn't reimburse for a particular program, but there are some opportunities through some of the reform efforts that we're seeing. And Debbie mentioned the Medicaid First 1,000 Days in New York. There are a couple of others where because particular programs have a very strong evidence base and stakeholders supporting spread and scale of those opportunities, that some Medicaid agencies have said, and some managed care plans have said, we would like to use the resources that we have available to support those particular programs. And so, for example, in New York, Healthy Steps is one of the points on the 10-point plan for how Medicaid is going to support healthy child development in the first 1,000 days. Reach Out and Read is another example in New York and other places as well. So my message here is there's more than one way to accomplish the goal that you are setting out to accomplish. It could either be by working through state managed care contracts, using that as a tool, individual managed care plans, talking with them about how they're allocating their flexible spending authority, or it could be looking specifically at the services that are delivered under a particular program to see what could be coverable under the Medicaid program. It's this kind of customized technical assistance and help that might be most useful to some of the folks on the phone as they pursue some of the goals that they have.
Thank you, Donna. I can only echo that it's so place specific, and using these multiple portals for entry into a collaborative relationship that then can develop into encouraging Medicaid directors to do work that they may already want to do, they just don't have the capacity to do, could be very powerful. And I'd like eventually to get to some examples of small pilots or small tests of change that you could recommend or give an example. I'll let the panel kind of ruminate on that first. And I'm going to send another question to Donna's way. So while Donna's answering this next question, we can ruminate on what are some bite-sized pilot project tests of change that a interested group could take if they want to affect policy for early childhood in their state. Okay, Donna, Here you go. You're really on the hot seat. Two questions that are related. One is there about childcare and finding out about insurance coverage? So as as you pointed out, childcare is a way to access really early childhood, period. Is there data through childcare provision about insurance in different states that can be used? And secondly, so that's just a data question, are there policy recommendations about how child care block grants could be used to promote insurance coverage?
So thanks for that question. I'm not 100% sure I understand the first part of it. However, I would recommend and can share with you a link to a policy memo that came out of ACF. I want to say it was January 2016. I'll send you the link where it was a policy memo that explicated some of the requirements for state child care programs related to various provisions of the child care block grant. And in that memo, there were specific issues related to health coverage, enrollment, consumer engagement, family engagement around health coverage and care. And so that's something that could be of great benefit to some of the folks on the phone that are thinking about how state agencies and state advisory groups can help forge a partnership between child care, Head Start, Medicaid, much of the kinds of things that Debbie was talking about earlier. So Elizabeth, I'm happy to send that link your way.
Yeah, and we will in turn distribute it to the folks on this call. The next question is one of what are little tests of change, bite-sized experiments, and Debbie Chang gave us some examples of what she's doing. So from, let's say you weren't a past CHIP director and you didn't happen to have an executive role at Nemours, but you're family advocacy or you're a parent engaged parent. What are some of the, and I think you suggested maybe maternal depression, but what are some of the bite-sized projects you might want to try to find collaborators for and test out? That could be to Debbie or Donna or Christy.
Kind of a hard question to answer because it really depends on the state, right? What's going on in the state and what folks are trying to do. You know, I gave this is Debbie. I gave a couple examples with respect to embedding the dietitian at the Head Start, and then of course what we're doing in DC. There were two questions that came up on that I just thought I would answer really quickly. On the DC one, somebody raised the question of, stapling a paper version rather than using electronic. And yes, we did look into, whether or not, there was a system that, because ideally you want a system that integrates the two data systems, but that really doesn't exist between childcare and pediatric systems, right? So anyways, the way that was the easiest, because we were trying to really come up with something that was easiest and could be worked into the flow process that already exists for a childcare provider or for a clinical provider. And since they already have these other forms, it was the easiest thing. And this came from the doctors and the childcare providers themselves. The easiest thing was to staple the results to this document that they knew that they needed. And so I suspect that, in the clinical world, we have a lot of things that are, electronic and whatnot. But I think in other different sectors, it's a vastly different world. And so I think, we came up with the best we could. And there was a question raised about the mini pilot we did in Maryland. And the issue for the dietitian was the dietitian was paid, right, wasn't getting enough payment basically with just two patients, even working with the families, like as the person suggested. We also suggested that it wasn't enough revenue to make it worthwhile for this particular dietitian to travel. She had to travel like, I guess, an hour or so. And so you have to look at the volume issues for the providers too, in terms of, is it right? You have to have enough volume to make it worthwhile for the provider to participate. I mean, so that's just a reality, I think, of working with various providers. And finally, Jenny Bissell had something which it is really true, that there's an opportunity to strengthen your relationship with your local MCOs, because they have RNs and social workers that are dealing with children with complex medical and special healthcare needs. And that would be a great pilot, because, you're probably also trying to deal with the coordinated needs of children with special needs in particular. And the MCOs are supposed to be doing that. So that's a great one where you could actually partner with an MCO. If they did that part, you would do another part. And to finally add another point that was mentioned earlier, we did a whole paper that's on our website that I shared with you all, looking at managed care plans and Head Start, and the rationale for, how to work with managed care plans and get them to realize that actually working with Head Start is a great way to meet your mutual health goals, right? Because Head Start has all of these requirements on health. And those same requirements are the same requirements that MCOs have to meet with respect to performance. And so trying to build the case with the MCOs, that this is going to help you, I think is the best way to approach it. And the same for you, Jenny, if you're still on the line, Jenny Bissell. If the MCO is working, on these more complicated medical special healthcare needs, maybe there's a role that you all can play to complement that.
So this is Christy. I think one of the other things that we forget is that families can make also.
Oh, Christy, we might have lost you.
Okay. Now do you have me again?
Yes, thanks.
Okay. So looking at families and finding out what they need, especially in the early childhood centers where you have 1 or 2 or 3 kids, families who are all having the same problem, figure out how that commonality is a need also in Medicaid. As Donna has said so well, as Debbie has said so well, there are requirements that, like Medicaid, keep track of how many early screenings that they're getting. And if that's a goal for them, and you're seeing that kiddos are going to the doctor and not getting screenings, or you all in your centers could be doing screenings and billing for them through Medicaid, ensuring that those kids get those screenings, then you've got your commonality and you can move forward with that. So it's figuring out what the needs are, and there's data that talks about families having to miss work because of kiddos with special needs. There's data that state by state talks about what families actually need. And that's where I always suggest starting, because a family saying we have a need is significant. The reason we have home and community-based waivers at all in this country is because families took a stand.
That makes a lot of sense to integrate what you're saying. The answers are really local and state-based, which is not a surprise, that the passion and the needs of the families should drive the priorities. But then you have the success when you align those with, the core sets of measures. Both Don and Debbie have emphasized this before, the measures driving the decisions among the other policy makers. I think we have to make sure other people's microphones are muted for a little bit less feedback as we dive into some of our final questions. We have a good friend, Charlie Bruner, who's asked, what are the best examples of states funding Healthy Steps, Help Me Grow, and various home visiting programs, particularly Child First, NFP, Healthy Families, and PAT as preventative services and or case management, targeted case management services. Anybody want to bring some of those to light?
So this is Donna, and Charlie, thanks for that question. I think we mentioned already that New York State's approach, which is a state Medicaid agency approach, but is working through managed care agencies, is a great example of how the state Medicaid agency is supporting some of the very programs that you're talking about, Healthy Steps being one, the home visiting programs as another. As I mentioned earlier, the state of Oklahoma has just begun implementing a health services initiative through CHIP that is supporting Reach Out and Read, which many of you know is an early literacy program that is delivered through pediatric practices and also helps to foster social and emotional development of young children. And again, I think the issue is that that brings both these two examples together is that it is the state agency that is using the authority that it has to support interventions that have strong evidence bases in terms of what can be accomplished for children and families. I just wanted to also take the opportunity to piggyback and echo the point that Debbie was making a little while ago about an important way to work with not just the state Medicaid agency, but also individual managed care plans, for example, or hospitals, health systems. A really important strategy is for the early childhood programs to understand what kinds of problems the healthcare entities are trying to solve and to make the case that working with them can help solve those problems. So, for example, if a managed care plan is finding that it's not doing so well on compliance with the well child visit periodicity schedule. In other words, children aren't coming in on the regular basis that they should for well child visits. Is there something that we can offer through the early childhood realm that can help those managed care plans improve that profile? And the reason this is important is because these performance measures may dictate the amount of money that they get or the way that they are viewed with respect to honoring the obligations of their contract with the state or other obligations that they have. So we always should be thinking about how we help other people solve their problems so that they benefit and also the children and families that we care about benefit as well. So I think Debbie's point was very well taken, and I wanted to emphasize that. And some of the programs that Charlie is raising are great ways to accomplish that goal.
That sounds great. And I wanted to note that we've actually had a lot of retention throughout this Q&A period. 100 of our folks have stayed on throughout it, and now people are starting to get off. So we're going to have maybe one or two more specific questions. We have some really specific questions. One here is from Maria, and it's, our NCAH department receives Title 19 funding. Is this not Medicaid funding? Is Title 19 considered a block grant? Thanks.
So Title 19 is the section of the Social Security Act for Medicaid. And Medicaid is an entitlement program. It is not a block grant. So it's an entitlement to individuals.
Okay,
Does that
and
help?
then Robert just had a clarifying question. I can find it here. Can we be more specific? Can CHIP and Medicaid fund healthy steps?
So I thank you for that question, because it makes me think that I need to clarify what I was trying to convey earlier. The answer is through different use of the authorities under Medicaid and CHIP, healthy steps can get support. So through the use of managed care opportunities, the program itself could be supported through particular managed care plans if the case can be made that they should do it and they agree. If you're working directly with, thinking about how Medicaid could support the particular activities of those programs, another way to look at this is to look at the kinds of activities that are delivered, or the kinds of services that are delivered through those programs.
Oh, it looks like we temporarily lost Donna. What a cliffhanger. Unfortunately, unless you pops back on really quickly, we have 2 more minutes. We want to tell everyone involved in this call that we'd like to continue this collaboration among all the agencies and the experts on this call, and more to support folks in evolving what their plans are and their relationships and collaborations are in their specific states, to move and improve opportunities for early childhood through innovative funding mechanisms. This call is officially concluded, but I'm going to offer a chance for anyone on our panel of experts to impart any final words of wisdom quickly as we conclude in the last minute. Debbie, Christy, Debbie, or Donna, if you're still on the phone, anyone have a final charge for our folks?
I would just say, reach out to your partner. It doesn't have to be a big thing, but just start building that relationship. And most importantly, to really, figure out what you're trying to do. How does that feed in to the priorities of the Medicaid and CHIP programs? Because as I said earlier, they are so strapped, they're so busy that it kind of needs to fit into their priority so that it's a shared priority. But I just really wanted to thank NICHQ for putting this together. I've got to run to another call, but I really appreciate your putting this together and being a part of this wonderful panel. Thank you so much, everyone.
Thank you.
This is Christy. When in Colorado, one of the things that we've done for a lot of years is had an advisory that has to do with children with special needs and Medicaid. And we have everybody from case managers to Medicaid to sitting at the same table, talking about the barriers that families that exist for families, because they hit more systems faster when there's kids with special needs. And so we have a conversation that's a very safe conversation to identify those barriers. And then those barriers are what we identify as things we take forward to make change. And they're things that everybody is working together on, like Medicaid. It's a goal for them as well as the families to remove those barriers. So it's a suggestion and a starting place to have a meeting and that open dialogue. Thank you for the time to do this call.
Absolutely. And we also have Debbie here to impart some wisdom to us. She has been persistent, which is one of the lessons of this call, is to be persistent in your endeavors. Debbie?
Hi, can you finally hear me?
Yes.
Great, thank you. I had to switch computers. I just wanted to encourage everyone to really, particularly the Title V agencies, to look at their interagency agreement requirement with Title 19 and to really think about how they can share resources because they are serving some of the same children. to look at how you can expand that interagency agreement to maybe incorporate maybe case management, maybe the Medicaid administrative claiming with identifying children that are potentially Medicaid eligible and families that are not currently enrolled. And so those are some mechanisms that can help you with gaining that partnership. Thank you.
Thank you, Debbie. And thanks again to our whole panel and everyone on the call. Final reminder, we're going to send out the deck of slides as well as a link to the transcript and probably an assessment of how this was helpful or what other questions remain and what we can do in the future to help you. So please be looking for that. Your feedback is not just welcome, but we really do act on it. And we hope to join you for the next webinar. Thanks to our panel, and thanks again to every participant who took the time out to learn about this. Bye.